got through the introductions and the formalities to introduce our first speaker, Dr. Doug Kerr. Yvonne has already mentioned his visit to us before. Doug is, in fact, a remarkable person, and we are incredibly lucky to have him with us today. In the past, he has led multidisciplinary research teams dedicated totally to the advancement of treatment of autoimmune neurologic disorders. He was once quoted as saying, "I will not stop until I have cured myelitis, transverse myelitis." It says on the screen in front of you where he is from, so I won't do the promotional bit, but I would just ask you please to welcome Doug Kerr, and we look forward to
Good morning. So for those who were in London at the 2007 meeting, I was not at a company called Biogen IDEC back then. I was at Johns Hopkins and had a Transverse Myelitis Center. And so let me start just by saying what Biogen IDEC is. It's a biotechnology company that's based in Cambridge, Massachusetts, right between Harvard and MIT, and basically evolved out of some science at Harvard and MIT. We have a large group in Maidenhead, just outside of out of London. And it is a company that is developing new therapies for neurologic disorders. It has therapies currently for multiple sclerosis, namely interferon, Aponex, as well as natalizumab, which is Tysabri. And the main driver for me to go there is really to develop therapies for neurologic disorders with high unmet need. In other words, disorders for which there isn't an appropriate therapeutic strategy in place. And so we are very interested in continuing to find a cure, a treatment for transverse myelitis. So the work that I began and many others continue at Johns Hopkins and elsewhere is continuing. And now what we're hoping to do is to develop therapies in clinical trials for transverse myelitis at Biogen IDEC. So I'm going to tell you a little bit about my experience with transverse myelitis over the last 15 years. And then a little bit later, I'm going to tell you what we hope to do to really develop therapies that allow the spinal cord to repair. So that's really one of the focuses that we will have at Biogen, is to explore new therapies that allow the nervous system, the spinal cord specifically, to remyelinate, to repair itself. So it's very exciting to be able to lead that effort from the other side while still working with my academic colleagues throughout the world. So to start my talk, you need to become neuroscientists. You need to learn about neuroanatomy. So that's what we're starting with. We need to learn what the spinal cord is and how does it work, because that's going to explain the symptoms that you have had and in many cases continue to have. So the brain is the organ that controls all parts of the body and is connected to the spinal cord, which comes down from the brain and facilitates the interactions between the brain and the rest of the body. Now, the brain is made up of millions of cells called neurons. These are small cells that work as essentially computer chips that activate electrical impulses going to and fro from one side of the brain to the other, up to the brain, down to the brain, and it's millions of these little computer chips and their electric wires that form these electrical circuits. Really, that's what it is. Your brain and spinal cord is millions of little electrical circuits. What you're looking at here on the top right is obviously a picture of the brain from some unfortunate soul, and what you're looking at on the bottom right is a microscopic image, and the little brown spots, I don't have a pointer, but I think you can tell me where to find a pointer here. Actually, can you see this? Yeah. Okay, so maybe I can just do it that way. Each of these brown spots is a neuron, and it's called a cell body, and then the axon is the wire that comes out from it that is connected to other neurons. So let's look at a cartoon of what a neuron is. Here is that cell body, and here is this axon. It's quite short here. In truth, an axon can be a meter long. It can start in the very top of your brain and go all the way down your spinal cord. Oh, thank you. Although the people in the back couldn't see it if I do this. Maybe it's better if I actually do it on the computer. So that axon is a meter long, connecting one neuron with another neuron, or the spinal cord with muscle. So it can be very long. And in order to conduct this electrical impulse along this axon, you need insulation. Just like the wiring in your house needs insulation around the wire, so does the nervous system. So do the axons in the nervous system. So what makes that myelin? Well, it's a particular cell called an oligodendrocyte that goes right next to this axon and wraps around it, this layer of insulation, and it wraps it many, many times. And it does so the entire length of the axon. So when you hear about a demyelinating disorder, and transverse myelitis is a demyelinating disorder, as is multiple sclerosis, and there are various cousins thereof that we will talk about, they are all demyelinating disorders, which means the insulation is stripped, and the axon, or the wire, is now bare. So in your house, in the wires in your house, if you strip off the insulation, what happens? Short circuit, right? So the light doesn't go on, or it flickers, or it blows. Well, that's what's happening in your nervous system, except now we're talking about movement, strength, sensation, bowel and bladder function. Those are all short circuits. And those are all short circuits that are caused by demyelination when the wrapping around these axons is damaged by the immune system. So the neuron is a chemical and electronic factory. You can see another cartoon here where it sends a signal down the axon and then triggers an impulse, and now the muscle moves. That's how we move. So an electrical impulse starts in the brain, goes down one of these very long axons down to the spinal cord, and then has this synapse, or it sends an impulse to another neuron that goes out to muscle. And when we want to move, we trigger an impulse in the brain that goes down, goes out to the muscle, and we move. So when we can't move because of paralysis, this circuit is interrupted, and it's interrupted because of demyelination along the way. So the electrical impulse starts in the brain, but it doesn't get there. It short circuits along the way. So just another view of this. This is just another cartoon, but here you're seeing these oligodendrocytes. So these are the support cells that reach out and wrap themselves around these axons that are in the brain and spinal cord. There's another cell type in the nervous system called the astrocyte. The astrocyte is a support cell that also allows kind of what gets into the brain and what gets out of the brain in terms of nutrients. The astrocyte is probably a bit more important in neuromyelitis optica, or NMO, or Devick's disease. And in fact, the astrocyte may be the target of the immune attack in NMO, whereas in transverse myelitis and multiple sclerosis, the target of the attack may be the oligodendrocyte. It may be slightly different in that regard. So here's a look at the spinal cord. So you're seeing a view here from the side in another cartoon, and these are all the bones, the vertebral column that protects the spinal cord and allows us to avoid traumatic injury to the spinal cord. And here's a side view of an MRI, and you can see the gray here is the brain. This happens to be the brain stem. White in this case is cerebrospinal fluid, or CSF. That's what you get when you do a lumbar puncture. That is actually bathing the brain in the spinal cord. And then this gray tube here is basically a bunch of wires going up to and down from the brain. And depending on what we're talking about, whether it's motor or sensory or bowel or bladder, each of these wires or axons go to different parts of the spinal cord and different parts of the brain. And that's why some people, depending on where their attack occurred, may have more sensory complaints, or more motor complaints, or more bowel and bladder complaints, because different circuits are affected depending on where the inflammation was. So the way to think about that is sensory function is really the wires going up to the brain. So we've all got millions of sensory endings in our skin, in our muscles, in our bowel and bladder, and they will start an electrical impulse that goes into the spinal cord, as shown here, and then up to the brain, and gives us the sensory feedback that says, wow, there's a very hot object on my hand right now, I better remove it. So that's sensation. And when that circuit short circuits, you get symptoms like pain, or a lack of sensation, numbness. And in some cases, it's a very uncomfortable, abnormal sensation, pins and needles or burning. And it can also cause a lack of balance because these sensory fibers in your skin and muscles allow us to maintain our balance without falling. So that when there's a short circuit of that, we may fall. So that's one part of that. That's the sensory information that is supposed to get into the brain to tell us what we're feeling and where we are in space. And when that short circuits, that's part of the symptomatology of transverse myelitis. The other is the motor pathway. We talked about that. That's the descending pathway. That impulse starts in the brain, goes down through the brain stem and out to the muscle and allows us to move. Such that when that short circuits, weakness, paralysis, stiffness, clonus, which is this repetitive movements that you can't control, and sometimes cramps. So that's a short circuiting of the motor pathway. So how did this begin for me? Well, it began really back in 1999, and there was the first Transverse Myelitis Association meeting in Seattle. It was much smaller than this. It was about 40 people and me. The only scientist, there were no physios there was nobody else. It was the very beginning of this. But I was struck by the need to study transverse myelitis. I was struck by the passion and the courage of the people who had it, and set up a transverse myelitis center at Johns Hopkins shortly thereafter and have been in ever since. And when we set up the Transverse Myelitis Center, it was a multidisciplinary center for clinical care, clinical research, and basic science research. So how could we understand transverse myelitis and the rest of these disorders that look like transverse myelitis? And so we had the opportunity then over the 10 years to see over 2,500 transverse myelitis patients. That's an awful lot of transverse myelitis patients. It gave us an opportunity to help those 2,500 patients, but also to learn from them and to sort out what this disease is. That Transverse Myelitis Center continues. You'll hear from Daniel Becker. Daniel, where are you? Daniel is in the back. Daniel is directing the Transverse Myelitis Center at Johns Hopkins. Some of you may know another colleague of mine, Benjamin Greenberg, who I trained at Johns Hopkins and has now got his own Transverse Myelitis Center in Dallas. So we're spreading. There are now becoming more and more transverse myelitis centers, which I think bodes very well. There's a lot of interest in this disorder, and ultimately, as I said, we're going to start doing clinical trials to try to improve function in patients with transverse myelitis. So one of the consequences of that Transverse Myelitis Center was that we first recognized that nobody knew what it was, nobody knew how to define it, nobody knew whether you had transverse myelitis or something else that people couldn't define. So we set up diagnostic criteria, and I'm not going to read through this, but this is a group in 2002 that got together, and I locked us all into a room and said we cannot leave the room until we decide what is transverse myelitis, what are the consensus criteria, and then also what is neuromyelitis optica, and what is MS, and what is ADEM. I don't know if any of you have heard of ADEM, acute disseminated encephalomyelitis. It's another cousin of these. And the other consequence of this 2002 paper that came out, which said exactly what transverse myelitis is, we provided an algorithm. It's a tree that says, okay, if somebody comes in and they have a spinal cord problem, what do you, a clinician or practitioner, do? What do you look for? And then if you find this, where do you go? Where do you go? So it provides a treatment and diagnostic algorithm for emergency rooms, for family practitioners, and for neurologists. And this has been updated really every year since 2002 to be more comprehensive in allowing treating physicians and therapists to understand what the disease is and how you should go about further diagnosing it. So then we had a children's symposium. This is the first one that I attended, which was in Columbus, Ohio in 2002. And you can see Sandy Siegel. Many of you may know Sandy Siegel, who is the president of the Transverse Myelitis Association. I'm in there. Greg Barnes is a pediatric neurologist, and Leslie Morrison as well. So we're starting to really get a bunch of information on transverse myelitis in kids. And this is in 2006 at the Victory Junction Camp in North Carolina. Ashley is a wonderful woman who had acute disseminated encephalomyelitis. And at this camp, where there's a whole bunch of activities, and it's really an amazing camp for transverse myelitis kids and adolescents. And we all go there every year as part of this camp. And I've seen her not only 2006, but 7, 8, 9, and 10. And Ashley has had this ongoing, continued recovery each year that we've been there. It's been very remarkable to see. And that, again, is Sandy Siegel on the left. So one of the other, I think, advances that we made when we started studying transverse myelitis is we figured out really several of the pieces that cause transverse myelitis. And one of the things that we found was important is a cytokine, which is a little protein, an inflammatory protein called IL-6 or interleukin-6. And we found that it was very elevated in the acute phases of transverse myelitis. And we found out to some degree what triggers interleukin-6, and then we figured out how interleukin-6 damages and causes demyelination to the spinal cord. And this is, I think, a very important advance because up until that point, nobody really knew what caused transverse myelitis. You just knew that there was some inflammation and then your spinal cord really stopped working. But to understand kind of the chemical processes and biological processes that do this was important because now it identifies targets, things that you can target to halt the inflammation, to halt the demyelination, or to trigger repair. So this is Maggie. Maggie is also at the Victory Junction camp. Maggie has transverse myelitis and is on a ventilator, has been since 2006. She is a mother of twins and got a high cervical transverse myelitis shortly after the birth of her twins and has come from a little rural fishing village in Alaska down to North Carolina for each of these camps and has done extremely well. Here you see that she's getting her hair done. And that's a mandatory part of the Victory Junction camp is you get your hair pink or green or something like that. What I won't show you is the pictures of me having had that done by my daughters. At the time, it was a bright fluorescent pink. And here is 2009, and this is a rodeo down in Dallas. So Ben Greenberg, I told you about, has a very good center in Dallas. And we had a transverse myelitis symposium in 2009 down there. That was very exciting, and we had a little bit of fun after one of the days. All right, so let's talk a little bit about transverse myelitis. It is an acute inflammatory disorder of a part of the spinal cord. It is immune-mediated, or you can also think of it as autoimmune, right? So your immune system normally fights off infectious agents, bacteria, and viruses. An autoimmune disorder is when the immune system starts to make a mistake, and instead of attacking infections, attacks you. And that's what an autoimmune disorder is. Diabetes is an autoimmune disorder in which there's an attack of the pancreas and affects insulin. There are thyroid autoimmune diseases. Lupus is an autoimmune disease in which the heart and the kidney is attacked. Well, in transverse myelitis, the site of the attack is the spinal cord. So for some reason, triggered by interleukin-6, the immune system starts to mess up and starts to attack your spinal cord as if it's a foreign substance worthy of attack. And that attack causes demyelination. And when the demyelination occurs, it results in motor dysfunction, we've talked about, weakness and spasticity, sensory dysfunction, such as numbness, paresthesias, which is a pins and needles sensation, dysesthesias, which is that uncomfortable, burning, kind of agonizing pain. In some people, it is outright pain. Autonomic dysfunction, which means sexual dysfunction and bowel and bladder dysfunction. Now, transverse myelitis usually is what we call monophasic, monofocal. Monophasic means one phase, one episode. It comes and it goes, and it has left in its wake demyelination and injury, but in most cases, about 90% of the time, does not come again. Monofocal means one region, as opposed to, say, MS, where there are attacks up and down the brain and all throughout the brain and the spinal cord. So what triggers it? Well, it's in many cases post-infectious. So an infection came in, triggered the immune system to activate, and then something happened where the immune system started to deviate and to make mistakes, and instead of just focusing on the infection, focuses on the spinal cord. And we have several leading theories as to why the infection does this. In some cases, the specific infection does this purposely, in a sense. To get the immune system away from attacking it, it creates a diversion. And the diversion is to your spinal cord, allowing this infectious agent to continue to grow and divide. What we don't know is why it's different in a particular patient. Why some people have it way up here in the top of the spinal cord, why some people it's down in the low part of the spinal cord, why in MS is it up in the brain. Those are things that we really don't know yet, and we've still got to figure out. So as you think about the spectrum of demyelinating diseases, there are many of them, but you can kind of categorize them. Transverse myelitis is really that one phase in the one region of the spinal cord. Optic neuritis is a very similar thing, but instead of the spinal cord, it's the optic nerve causing you to have blurred or decreased vision in one eye. Multiple sclerosis is by definition multiple phases that come again and again and again, and is multifocal, which means it's in the brain and the spinal cord. ADEM, I just mentioned, is one phase, but it's all over the place, multifocal. And neuromyelitis optica, or NMO, has a couple phases, 2 or 3 or 4 attacks, but it's just the spinal cord and the optic nerve. So those are the different categorizations of autoimmune demyelinating disorder. So transverse myelitis itself is rare. So 1 to 8 new cases per million people per year. So for each of you who has had transverse myelitis, you literally can say that you are 1 in a million. I don't know if that's comforting or not. Which means that there are about 34,000 people in the US that have had transverse myelitis, a similar amount in Europe, a similar amount of transverse myelitis in Asia, and neuromyelitis optica is much more common in Asia, such that there are about 90,000 NMO patients in Asia alone. So there are some ethnic factors that we can contribute to developing neuromyelitis optica. It's mainly in adults. About 3/4 of transverse myelitis does occur in adults. The mean age of onset is 35 years, but that doesn't tell the whole story. because it's really divided into groups in which there's kind of a peak incidence of transverse myelitis for those who are between 40 and 50 years, and also among children less than 10 years old. So there are kind of two peaks of the incidence of transverse myelitis, and there are many cases of transverse myelitis in newborns in the first year to 2 years of life, and we'll talk about that tomorrow morning. It's about the same males to females, no gender preponderance, and the mortality in the acute phase is 2.7%, and that really is just those who had a very high cervical transverse myelitis and couldn't get to hospital quick enough and had breathing problems. So what happens before the transverse myelitis? As we've looked at these patients to try to figure out what were the potential causes, many of you have told me about antecedent or preceding vaccinations or jabs. And it turns out about 15% of people who get transverse myelitis have had a vaccine within the 30 days prior to the transverse myelitis. We're not sure what that means. Some people will swear that their transverse myelitis was caused by the vaccine. In general, we think that vaccines are extremely safe and are extremely important, but you can't rule out that in a rare individual with some rare circumstance that the vaccine may have contributed in some sense. 35% had a preceding illness, and that's what we talked about before, where the illness actually triggers the immune system to start to really ramp up, and then the immune system starts to make a mistake. So that preceding illness really triggered the transverse myelitis. And many have told us, so it's about 20% of patients, some trauma, some fall where they fell on their butt or they twisted and felt a pop, that type of thing that precedes the onset of transverse myelitis. I'd be interested to hear how many people later had something like that. The idea being that particular trauma was not enough to actually directly injure the spinal cord, but instead altered the way the blood flow and the immune cells can get into the spinal cord and may have contributed to the transverse myelitis. So this is ongoing. We're very interested in collecting these data so that we know really what are the triggers and we can do more in-depth studies. All right, so let's talk again about the clinical presentations. And these are the four cardinal features of transverse myelitis: motor, sensory, autonomic, meaning bowel and bladder, and pain. Okay? So the motor can be weakness, and it could be slight weakness, all the way to paraplegia, which means no movement of the legs, or quadriplegia, which means no movement of the arms and legs. Typically it involves the legs greater than the arms, and so that the arms are relatively preserved, but that's not always the case, and that depends just where the lesion occurs. Tone, resting muscle tone, in the acute phase of transverse myelitis can be really stiff, it could be normal, or it could be really floppy. So decreased tone would be floppy or hypotonia. But after the acute phase of transverse myelitis, most patients have increased tone. Their muscles are really stiff, they have trouble coordinating those muscles, and that's because of the short-circuiting of the motor pathway, so the motor systems are activated all over the place rather than being quiet when you're not trying to move your legs or arms. And the sensory complaints are, in many cases, the things that bother patients the most. When they talk to me, they say, look, I'm weak, but really it's these sensory abnormalities that really bother me the most. This pins and needles sensation, numbness, warmth, burning. And typically, one way to think about it is numbness may be really the absence of sensation, right? So you can't feel anything, meaning that sensory system going up to the brain doesn't get there at all. It's just not active at that time. Whereas this pins and needles sensation or warmth is different. It says the sensory system is alive and kicking, it's just giving the wrong information. So in some cases, a patient will come in and say, you know, I've really got these pins and needles sensation or warmth or burning, and I say, good. And they say, why good? That's not very comfortable. I'm not very happy about this. And I say, because it tells you that the circuit is intact, and it's trying to wake up, and it's trying to recalibrate. So in some cases, although uncomfortable, does in some senses signify that the sensory pathway is intact. Autonomic dysfunction can be also a variety of things, from urinary urgency, which really is gotta pee now, right? Many people will have that, where once they get the sensation to pee, they gotta go, and they can't wait. And the reason is that the bladder starts to distend with urine, and normally what people without transverse myelitis can do is they can send an impulse to the bladder to say, be quiet, relax. I'm in a very good lecture right now, and I don't want to have to go to that. But in transverse myelitis, you can't send that inhibition, so that when the bladder fills with urine, it does what it's got to do. It tells you, go pee. It can also be urinary retention, which means that the muscles of the bladder just simply can't be coordinated to work, and in that case, you may have to have catheterization. Bowel urgency and retention is quite similar and often parallels urinary urgency and retention, and sexual dysfunction is common after transverse myelitis for the same reason, that those autonomic circuits that go to the bladder and go to the bowel are also important for sexual function. And the pain. These are just direct quotes from patients. Burning, radicular pain, tight squeezing, banding, deep agonizing pain. And there are some treatments for this, but in some cases it is difficult to treat this. And there's a cascade of things that one can do to treat this, starting with very simple medicines like gabapentin, and then moving up to more aggressive therapies that usually can be helpful, but sometimes it takes things like a pump or a stimulator that's placed adjacent to the spinal cord to really effectively get control. All right, so I don't want to take too much time going over the experience of who has what, but numbness is very common, sensory changes, virtually everybody has this at the beginning of the transverse myelitis. Pain in 2/3, 68%, and in some cases, those who had pain at the outset actually had a bit more injury and had a bit more protracted or slower ultimate recovery. Bladder function in the acute phase of transverse myelitis, again, about 2/3 of patients required intermittent catheterization during the acute phase, many fewer down the road. So in many cases, that was just an acute thing that for 2 months or 3 months or 6 months needed catheterization, and ultimately you could urinate on your own after that. So how is transverse myelitis treated? Typically IV steroids is given in the acute phase. If you can get to hospital quick enough, IV steroids is likely to be helpful, but sometimes it takes too long to get to hospital and physicians aren't particularly comfortable with this, and so they may not institute therapy right away. IVIG, intravenous immunoglobulin, is used in a few. Acyclovir is an antiviral agent which is used by a few. Some patients go on antibiotics, and plasmapheresis or plasma exchange is only used by about 8%, but can be very effective in the acute phase if somebody's not getting rapidly better with steroids. So the MRI is important in the acute phase. Why? Because 88% of the time it's abnormal and it says, look, here is the region of the spinal cord that's inflamed. So it's very helpful in defining this is the transverse myelitis and this is where it is, and you can start treatment. Whereas without the MRI, you may have more uncertainty for a longer period of time. A lumbar puncture is often done, many of you know. It's the tap to collect spinal fluid, and it is abnormal in about half of the patients. So half can have true transverse myelitis, but don't have an abnormality such as an elevated protein or an elevated white blood cell count. Now recurrence is a big issue, because I told you that this is a monophasic disorder, one phase. that it won't come again. Now there is, in some, about 10% a recurrence of transverse myelitis, which really is recurrent clinical symptoms attributable to spinal cord, and the cases must have had a return to abnormal CSF. In other words, the second attack met the criteria for transverse myelitis as well. It does occur. In our initial series, it was actually almost a quarter, so 24% of the cases had recurrent transverse myelitis. All told, it's about 10%. So we spent a lot of time and think that you can really predict at the outset, with some degree of certainty, those who will recur from those who won't. And I won't go into all of the features that help us know that, but it's important to actually ask, what is my risk of recurrence? The MRI will help, the MRI of the brain will help, the spinal fluid will help, and the clinical features will also help. So we think if we look at those features and say, you don't have this, you don't have this, you don't have this, in that context, the risk of recurrence is actually very low, in the order of 1 to 2%. So it's 10% overall, but it depends whether you've got that particular MRI feature or a particular clinical feature that really should be evaluated. It's one of the things that we're trying to educate physicians to look at more, because it's one of the most important things out there. Is what is my risk of having this horrible thing come again? Okay. These are just some of the features from a paper that I published, which basically says these are the things that sort between monophasic and recurrent transverse myelitis. Okay, so I'm going to end and just show a few slides, but this is really how far we've come since 1999. This may not make a whole lot of sense to all of you, but this pathway of things that occur in transverse myelitis is important, because now companies and drugs that target that specific pathway can be brought to bear against transverse myelitis. So TNF-alpha is one of the very early things. IL-6 I've already mentioned. And all of these we think are in order activated that cause injury in transverse myelitis. And so it gives rise to the notion that in the acute phase, you can block these various factors by a bunch of things. Thalidomide is a drug that in the acute phase can be very effective. Erythropoietin, statins, antioxidants, PARP inhibitors. And what in the yellow box down at the bottom is really kind of the initial clinical trials that I think will be run in transverse myelitis. And the reason for this is as follows. Look at the green arrow down the right side of the screen. All of that stuff occurs in hours to days. So it's very quick. So it's very hard to intervene in that short period of time, especially because patients are seen out in community hospitals where there may not be as much attention to these types of things. But once we talk about the bottom arrow, which occurs over days to months, we can really alter the inflammation. We can potentially trigger remyelination. We can potentially repair the nervous system with stem cells. And what you'll hear from me and from others is functional electrical stimulation, which is very, very important therapeutic modality. May not only help you feel better and function better, it may actually start to rewire the nervous system. In other words, activity itself sends a signal back to the spinal cord to repair and to remyelinate. So these are the types of therapies that can be initiated even after that first acute hours to days onset of transverse myelitis. And I say days to months, but it could be years. So for example, the functional electrical stimulation doesn't need to be done in the first couple months. That's the kind of thing that has potential benefit even years later. Okay. A couple other things. We now have really good tools to start to look at the injury in the nervous system. Here is one. This is called optical coherence tomography. What you're looking at here is somebody's retina. And each of these layers is a layer of nerves that is involved in optic neuritis and MS and neuromyelitis optica, and so you can very precisely quantitate the injury and track recovery by using this tool. Here's another one. So this is an MRI, and what you're actually looking at are the wires that are going down from the brain to help somebody move. So to be able to look at them and quantify them allows us now to develop therapies and test whether the therapies are working by these modalities. Okay, couple take-home messages. One, I didn't mention this, but vitamin D. Vitamin D is important, right? So there's an epidemic of vitamin D deficiency. Most of you probably don't have sufficient vitamin D. As it turns out, vitamin D is important in regulating the immune system, and too low levels of vitamin D predispose the immune system to making mistakes, such as autoimmune attacks. So it's simple. It's get your vitamin D level checked, and you may need to be on D3, vitamin D3. You can get this at any nutritional store. A lot of people take it. Most of my patients take it, and you can check the blood levels. Okay? So vitamin D, that's one of the take-home messages. 2, FES, functional electrical stimulation. It's not the only modality. The point, though, is that activity triggers the nervous system to repair. Lack of activity doesn't tell the immune system to repair. So if you can be active, swimming, bicycling, doing any kind of activity, it is going to send the messages to the nervous system to repair. If you can't do it on your own, FES can help and can actually trigger this activity-based rehab that you will hear more about. And I'm not going to go over this, but we've done a study of FES in patients with progressive MS. These are patients who were in a wheelchair, and we looked at a series of outcome measures after they did the FES. The only thing I want you to know is green versus red, because we looked at all of these outcome measures and made the green ones mean that those got better, and the red ones mean that they got worse. So if you look at all of these outcome measures after FES, virtually all of them got better, such that the patients were, in many cases now, able to get out of the wheelchair and stand, take a few steps, as long as they were doing this functional electrical stimulation. So it's a very important thing for us to do. This is now now being published. Will come out in a couple weeks. And finally, stem cells. You'll hear about stem cells. We'll talk about stem cells. We can define where the stem cells go. In this case, these are millions of stem cells that have made it into the brain of an animal, but we're starting to get to that in humans. Stay tuned, those studies are coming. Okay, and drug companies do care about rare disorders. They do care about transverse myelitis, and the reason really is because there's a high unmet need. Nobody is doing anything for transverse myelitis in terms of repair of the nervous system, and we think we can do this. We think all of you out there need this, and so we are engaging this from Biogen, but also with my academic colleagues. So I'm going to stop there and take questions.